Let me start with this. We have many videos right now. We cover nearly 420 videos on different medical topics for USMLE and MRC research examinations, other board examinations. Just go through once. We made a different playlist so that it should be very easy for you to understand. It should be very useful for you to revise easily before going to examination. And what's the beauty and the good thing about our channel is we discuss only the important points. That's it. Okay, it's for important points for examination, board examination. That's it. Okay, so definitely I'm sure you like it. I'm damn sure. And if you have any suggestions, please do tell us. Okay, so try to concentrate and try to spend some time with us, and definitely you will go ahead very well. Right now I'm covering topics related to step 2 CK and step 3. So for step 1 we will be uploading, and we are working on that, and definitely we'll upload more videos on that, and we'll start uploading. The cluster headache, also known as a histamine headache, is a primary neurovascular primary headache disorder, the pathophysiology and the etiology of which are not well understood. As the name suggests, cluster headache involves a grouping of headaches, usually over a period of several weeks. So it comes in the groups, it comes in the cluster. That's why it's known as a cluster headache. According to the diagnostic criteria developed by the International Headache Society, as I discussed for migraine headache, in this the patient experiences attacks of severe or very severe, strictly unilateral orbital or supraorbital or temporal pain that lasts 15 to 180 minutes and occur from once every other day to 8 times a day. Look at these criteria, as these criteria are very important for you to diagnose the disease. In USMLE examination, you need to diagnose this disease on the basis of clinical science. No lab investigation or no pathological finding they give. What you need to diagnose is on the clinical basis. That's why I concentrate more on clinical findings. The attacks are associated with one or more following: all ipsilateral conjunctival injection, very important, lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, miosis, ptosis, and eyelid edema. The underlying pathophysiology of the cluster headache is incompletely understood. The periodicity of the attack suggests that the involvement of a biological clock within the hypothalamus with the central disinhibition of the nociceptive and autonomic pathways, specifically the trigeminal nociceptive pathways. This is not an important topic for USMLE examination or other board examination. If you try to remember, then it's good. Risk factor for cluster headache includes male sex, older than 30, small amounts of vasodilators, and previous head trauma or surgery. Here I would like to tell you that in USMLE examination they will give the history, and they will tell that the patient is suffering from cluster headache. Which of the following puts this patient at the high risk for cluster headache? So you should remember this. You should memorize this. Male sex, older than, because they give the age 35 years or 28 years age, and is non-alcoholic, and is working in a bank as a bank manager, and no history of any previous trauma or a surgery. Which of the following is a risk factor for this? Is the age, sex, or the his daily living, or anything like that, right? Okay, the attacks of the cluster headaches are typically short and occur with clear periodicity. So because of this, short and occur with a clear periodicity, the prophylaxis are not going to help in this patient as compared to the patients of migraine headache. That's what the beauty of this disease is. Particularly during sleep or early morning hours, usually corresponding with the onset of a rapid eye movement sleep. Unlike migraine CH, that is a cluster headache, is not preceded by aura, very important point, and is not usually accompanied by the symptoms such as nausea, vomiting, photophobia, and osmophobia. So remember these points. Typically, a patient experiences 1 to 2 cluster of periods per year, each lasting 2 weeks to 3 months. International Headache Society classifies, as I discussed before, the other points. Episodic cluster headache occurs in a period lasting from 7 days to 1 year. Cluster attacks are separated by pain-free intervals at least 1 month long. A chronic CH persists more than 1 year, either without remissions or with remissions shorter than 1 month. It is further divided into two subcategories: chronic CH from onset and chronic CH evolving from episodic CH. So no need to remember for USMLE examination. This is not a big topic for that. So try to concentrate on the clinical features in general. That's more than enough for you. The pain of CH manifested as follows: characters: excruciating, stabbing, sharp, lancinating, rather than throbbing. Location: unilateral. Look at this. This is usually a unilateral pain in the periorbital, retroorbital, and temporal regions. Though the pain sometimes radiates to the cheek, jaw, occipital, nuchal regions, and pains tend to remain on the same side during the cluster period, but in rare cases may switch sides. Distribution: first and the second division of the trigeminal nerve. Approximately 18 to 20% of the patients complain of pain in the extra trigeminal areas, that is the back of the neck along the carotid artery. That comes in the neck, right? Onset: like sudden peaking in a 10 to 15 minutes, duration 5 minutes to 3 hours per episode, frequency may occur 1 to 8 times a day for as long as 4 months. Look at this. It's so frustrating, right? Really, it's so frustrating for people. I feel so pity on them. A periodicity, circadian regularity in 47%. No need to remember any percentage. Remissions: long symptom-free interval occurring in some patients. Length of these remissions average 2 years, but may range from 2 months to 20 years. Pain is accompanied by various cranial parasympathetic symptoms, including the following: ipsilateral lacrimation, nasal stiffness. Sometimes they can ask you which of the following could be the most common symptom, okay, other than the headache in a cluster headache patients. Okay, ipsilateral meiosis or atosis, ipsilateral forehead or facial precipitation, alcohol products, and tobacco may precipitate an attack. What are the things that precipitate migrainous headache? Tell me. Okay, let me revise for you. It's a cheese, caffeine, menstruation, chocolates, and oral contraceptives. And here, like alcohol products and tobacco. That's why alcohol products and tobacco most commonly seen in the men, but nowadays it's common in females also. But that's why you can remember the way in which you can remember. Other trigger includes hot weather, watching television, nitroglycerin, stress, relaxation, extreme temperatures, glare, allergic rhinitis, and sexual activity. During an attack of CH, as many as 90% of the patient may become agitated and extreme restless. They do not like to lie down to the rest, and instead they prefer to pace or move around. In desperation, patients may rock, sit, pace, bang themselves against a hard surface, scream in pain, or crawl on the floor. So look at the severity of the pain. This is very severe pain. Structural lesions have been described with the CH and should be suspected if the presentation is atypical. Atypical present features may include absence of periodic pattern, residual headache between exacerbation, volatility, incomplete or minimal response to the standard therapy, presence of unilateralizing findings on examination. Okay, characteristic finding of this are distinctive facial appearance, leonine faces, multifurrowed furrowed and thickened skin with a prominent folds and broad chin, vertical forehead crease, nasal telangiectasias, parasympathetic overactivities, ipsilateral lacrimation, conjunctival injections, rhinorrhea, congestion, Horner's syndrome, bradycardia, facial flushing, scalp and facial tenderness, ipsilateral carotid tenderness. Sorry. Okay, they can be classified. How do you treat it? This is very important topic. Rest, the best initial therapy, you can start with the sumatriptan. This is very important, same as that what we see in the patient of migrainous headache. But the other thing what you need to remember for a cluster headache patient is 100% oxygen or a steroid. Very important points, very important points. If the patient is having, if a known case of very well known case of a cluster headache comes to ER, that's the emergency room or emergency department with a severe headache, what you need to do is the first step is to give oxygen, 100% oxygen. Then you can give somatropin or a steroid. Okay. Right. So preventive prophylactic can be given: calcium channel blockers, mood stabilizers, anticonvulsants. But there's no definitive preventive or prophylactic therapy for these patients, because they come in the clusters and they go away, right? So it can be, but if you want, you can give the calcium channel blockers, mood stabilizers, anticonvulsants. Okay, guys. Try to I will try to make a table how to differentiate from migraine headache from the cluster headache, because this is very important, because whenever they give the option of cluster headache, definitely they will give you an option of migraine headache, and you should differentiate it. Okay, guys, thank you so much for watching my video on a cluster headache. I think I took a bit long, but definitely I discussed a very important point, and definitely will help you. Don't forget to tell your friends about our channel. Take care.